All right, thank you everyone for joining us today, and thank you, Rob, for that introduction. As you've gathered no doubt from the title, today's cyber seminar is a joint presentation by the Veterans Access Research Consortium, VARC, and the Virtual Care Corps. To begin with, we'd like to start with a poll to understand who's with us today. So if you could please answer the poll in the polling on the right-hand side of your screen, that'd be great. We'll pause for a moment to let people do that.
Thank you, Dr. Shimada. The question is, which is your primary role in VA? And the answer options are A, research investigator, meaning principal investigator or co-investigator. B, postdoctoral fellow, student, or trainee. C, project manager, coordinator, admin. D, statistician or data analyst. E, clinician. F, VA operations. G, other. And if you answer other, go ahead and send something to the chat if you like as to what other means to you. And if I get it in time, I'll read it off. And I think we've given people enough time, Stephanie, so I'm going to go ahead and close the poll. And I'm going to share the results, and then I will read them to you. Give me a second to open this up a little bit better. It looks like 18% answered A, research investigator. Only 7% answered B, postdoctoral fellow, student trainee. 15% C, project manager, coordinator, admin. 7% statistician or data analyst. Another 7% E, clinician. Only 4% VA operations, and only 1% answered other, and nobody entered what other means to them. So back to you.
Right. Great, thanks so much, Rob. It's always helpful to see who's in the audience, and I'm glad we have a diversity of perspectives here today. So I wanted to go over what's a pretty packed agenda for today's cyber seminar. So to begin with, Dr. Timothy Hogan and I will spend the first 10 to 12 minutes discussing the differences between the two cores, highlighting areas of overlapping interest and opportunities for synergy and collaboration. Then we'll move on to hearing from three wonderful researchers who are part of our cores. First, Dr. Paul Hebert from the Seattle VA will present results from an access-related study. Then Dr. Jolie Haun from the Tampa VA will present her work, which aligns with the Virtual Care Corps' goals. And last but not least, Dr. Charlie Wray from the San Francisco VA will present the aims of his recently funded HSR&D Career Development Award, which aligns with both of our cores. So what are the Access and Virtual Care Cores? And I wanted to highlight here that the Access Core, which I will refer to alternately as VARC, and the Access Core is one, well, I just wanted to highlight that when I'm saying those two words, I'm referring to the same thing. And then the Virtual Care Core is sometimes noted as the VC Core in our slides. I know that it can get a little confusing with both of them having the letter V in them. So I wanted to pause again just to gauge our audience to find out which describes your primary interest in research. So are you primarily interested in healthcare access research, virtual care research, or both? Again, the poll is on the right-hand side.
I opened it up as soon as you started mentioning it, and people are making their choices now. Looks like things are going along pretty quickly, so we'll be able to close it and review answers momentarily. Looks like things have leveled off, so I'm going to go ahead and close the poll in a second. Yeah, I'm going to go ahead and close the poll, and I'll share out the results, and then I'll read them to you. 13% say A, healthcare access, 12% B, virtual care, and 42% answered C, both A and B. Back to you.
Thanks, great. This is pretty much what we expected, but it's great to see that we have others joining as well. And hopefully it will be a worthwhile presentation for everyone involved. Excuse me. So first we wanted to start out, I think most people are aware of what the Consortia of REsearch are. but just in case, I wanted to highlight what our roles are and what our function is, I guess, in the HSR&D realm. So primarily, our goals are to support and accelerate research through identifying a prioritized set of research goals in a given priority area and building a collaborative network of researchers. So in order to support this, we work to identify key research priorities in each of our areas. We facilitate the development and execution of research and evaluation work. And we promote communication and collaboration with key program offices so that the work that we do as researchers is aligned with our operational goals for the VA as a whole. And hopefully by doing this, we leverage our collaborative network of researchers to support impactful research. What cores don't do is determine what the priorities are. We try to identify where the gaps are in the research and where we think the work should go, but we don't determine those funding priorities. We don't act as gatekeepers for funding or write letters of support for funding. And we don't serve as consultants for the operations staff, although we may be able to leverage our research networks to help them identify the necessary expertise. So now that I've covered sort of what the overall goals of these cores are, we want to take a little bit of time describing each of the cores individually. So first I'll cover VARC and then switch over to Dr. Hogan to discuss the virtual care core. So the Veterans Access and Research Consortium is led by Dr. Mike Ho in Denver, with Dr. Peter Kaboli, Dr. Samir Saini, and myself as the co-leads. Our funding began in January of 2020, and our operational partners are the Office of Veterans Access to Care and the Office of Rural Health. Our mission is to promote innovative, operationally aligned, high-priority research that will impact veterans' healthcare access in measurable and tangible ways. So in order to do so in the first 2 years, our goals are to build and support an Access Research Consortium network, which we refer to as the ARC network, conduct a portfolio review of access-related VA evaluation and research projects, develop an access metrics compendium, and identify those high-priority access research and access metric-related questions to help inform our access research roadmap. Those of you who are on our mailing list know that we are building an intranet site where a lot of these resources are posted and available for everyone to use. All right, so I need to, oh dear. Here we go. I want to hand it over to Dr. Hogan.
That's great, Stephanie. Thank you so much. Let me just tell folks a little bit about the Virtual Care Core. So the Virtual Care Core is led by Dr. Scott Sherman, Dr. Donna Zolman, and myself. And our mission is really to facilitate research that evaluates and improves the use of virtual care technologies to enhance accessibility, capacity, and quality of VA healthcare and the veteran experience. So kind of under that broad mission, we have various areas of interest. So certainly thinking about how we can leverage and best use the virtual care modalities that are out there in VA now to increase veteran access to services, how those technologies can improve the workflow of our clinical teams and our staff members, how they can help workload and maybe streamline work processes for staff and for clinicians. And then thinking more about this idea of engagement and support for veterans so that they can become more active participants in their own care through these technologies. Our work in the Virtual Care Core is really organized around 3 broad impact goals. So first, to facilitate increased adoption and use of virtual care technologies in VA. Second, to foster research on the impact of virtual care in VA. And then third, to create a network of virtual care investigators across our healthcare system that are aligned with the needs and priorities of relevant operational partners that are working in the space of virtual care. Within those impact goals, we have a variety of tasks and activities and deliverables we're working on. That includes a portfolio review, the development of compendiums of relevant measures to support virtual care research in VA, and also thinking about how we can best stand up more infrastructure to help researchers conduct this kind of work. We are sort of the newest core on the block, so we were funded in June of 2020 and launched our work then. And to date, we're really standing up 2 work groups. So we have a work group taking shape that's focused on supporting telemental health research, and another work group that is focused on how we can facilitate the use of common metrics and support data sharing among researchers who are doing virtual care research. That's a little bit about the virtual care core. Stephanie, I'm going to turn it back to you so you can help us do some thinking about how the cores relate to one another.
Great, thank you, Tim. So this Venn diagram gets to the differences in the overlap between the cores, and I think you've probably picked up by now that there are some areas of overlap. For example, the virtual care core's overall goal is to promote the adoption and use of virtual care technologies, whereas VARC's goal is to improve access across various dimensions, which include but are not limited to digital access. And jointly, we are interested in leveraging virtual care to improve access to healthcare and health information. VARC is interested in access measurement. The virtual care core is interested in measures of virtual care implementation and outcomes. And jointly, we're interested in measures of virtual access. Let me start here. VARC is interested in effective interventions to improve access. The virtual care core is interested in strategies that are associated with successful adoption and use of virtual care. And jointly, we're interested in identifying virtual care interventions that improve access and are ready for implementation. Both seek to further our understanding of the appropriate balance of in-person, virtual, and community care access. So I hope this highlights sort of some areas where there's a lot of potential for making meaningful progress forward. If we leverage the fact that roughly, 40-some% of our attendees are interested in this overlapping area, we hope many of you will become engaged in the work of the cores and help us move this forward. This isn't something that the core leadership are doing on our own. We're hoping that all HSR&D investigators will become engaged. So I'll turn it back to Tim to talk more about this synergy.
So thanks, Stephanie. And I really like this slide that Stephanie just presented, because it kind of gives us that visual of how these cores relate to one another, and kind of lays out these conceptual distinctions and points of overlap between the access core and the virtual care core. On this slide, what Stephanie and I really were hoping to do was just to talk for a minute about some of the ways that these conceptual similarities and points of overlap between the cores really translate into kind of more tangible goals and deliverables. This is obviously not an exhaustive list. This is sort of our thinking about these points of synergy and overlap. So here, thinking about these synergistic deliverables. So contributing jointly to virtual care access metrics and the identification of data sources as part of the VARC compendium of access metrics and the virtual care core virtual care measures repository. So both cores are working to identify metrics and data sources, and I think it's going to be very important for the cores to be in touch as we do that and compile those metrics and data sources. Second, identifying evidence-based virtual care interventions that are ready for implementation and that we could hopefully use to maximize access to care for veterans. Thinking about how we can collaborate on our portfolio reviews that both Stephanie and I mentioned to identify overlapping priority areas, gaps that we've both identified that are relevant to access-related research and virtual care research. And then lastly, thinking about how we can consider opportunities to create possible cross-core working groups to address some of these mutual areas of interest, some of the challenges in doing this kind of research that we have identified, is again that kind of another synergistic activity or deliverable that we can do. So Stephanie, if you could just turn us over to the next slide. And I'm not going to read through this in the interest of time, but the other point that Stephanie and I really wanted to make in this introduction to the cyber seminar is that you can see some of these conceptual similarities and distinctions in the projects that both the Access Core and the Virtual Care Core have already funded. And so on this slide, you see on the left-hand column just 3 projects that we felt really kind of exemplified more of a focus on the priorities of the Virtual Care Core. In the middle column of this slide, we highlighted 4 projects that we felt had sort of spoke to kind of the foci that are relevant both to the Access Core and the Virtual Care Core. And then lastly, on the right-hand side of this slide, just 3 projects that had a little bit more of an access focus. If folks are interested in learning more about any of these projects, please get in touch with Stephanie or me or other members of the core teams. We'd be happy to tell you about them. And similarly, on this slide, this is just an additional group of projects that have been funded through the Virtual Care Core. And what we've done here is highlighted in blue those projects that we feel address both the Access Core and Virtual Care Core priorities. So lots of potential synergies, points of overlap, some points of divergence as well. What we're going to ask the audience to do is kind of keep that in mind, and maybe we can come back to those ideas when we open it up for discussion after we hear from our 3 presenters. But what I'd like to do now is turn it over to our first investigator who's presenting. Dr. Paul Hebert is a core investigator at the Seattle-Denver COIN, and he is a research professor in the Department of Health Services at UW School of Public Health. And he's going to talk to us about routing calls to nurse practitioners and how that was associated with fewer emergency department and outpatient visits. So Paul, take it away.
Okay, thank you, Tim. So this is an evaluation of a program that was designed to improve access by placing nurse practitioners at a VA call center. Back in 2015, the Greater Los Angeles, the GLA call center, began a program where calls that came into the call center could be forwarded to a nurse practitioner. And the idea was that because nurse practitioners can order medications and tests, by routing the call to the nurse practitioner, you might obviate some face-to-face visits and speed the access to care for veterans. There have been some randomized trials of this, and some were found to be effective, some were found to be have no effect, and some had the opposite effect, it increased use. So this was an important evaluation. Our basic research question was routing calls to a nurse practitioner associated with lower subsequent in-person visits than routine handling of a similar call by a registered nurse? So this is how calls get routed to the nurse practitioner. This red line reflects calls that are for emergent conditions. So if a call comes into a call center and the patient might be having a heart attack or a wound that won't stop bleeding, it gets immediately reviewed by a registered nurse, and the patient is then referred directly to 911. Calls that are not for emergent conditions either go through this purple path, through one of these 2 purple paths, and then it goes to an RN that is operating this software called TEDP, Triage Expert Dual Purpose Software. And this software is going to ask the veteran a bunch of questions about the condition that they're calling for, and then make a recommendation on follow-up treatment. At this point, the RN that's using this software can decide to forward the call either to a routine management by an RN or to a nurse practitioner. This decision to make this this referral is important because you only want to send patients to the nurse practitioner who have conditions that the nurse practitioner could do something about. So if the nurse practitioner's got to palpitate something or has got to see something, it doesn't make any sense to send those types of conditions to the nurse practitioner since they'd have to come into the office anyways. But this TDP software creates a text note in CDW that we can then go and mine to get some really useful information. So here's an example of what the text note looks like. It has a chief complaint. CC is chief complaint. So this person came in with a chief complaint of headache. And then it asks a bunch of questions about other conditions that the person has or doesn't have. And then the software makes recommendations for the follow-up interval and the follow-up location. So these can be used in a somewhat clumsy manner to get at the urgency of the condition. And then there's some values and measures, for example, pain scores in here. And a lot of the calls that come to the call center are for pain. And of course, this is in CDW, so it's linked back to the patient's medical record, so we can get all of the subsequent and prior use. So here's a brief sketch of the methods. We're going to identify all of the TDP notes to calls for nurse practitioners and RNs from April 2015 to March 2019. We're going to restrict the sample to calls with chief complaints that were handled by NP, so that we're going to make an apples-to-apples comparison on conditions, and only calls that came in on days and times when NPs were working. This is an important restriction because if you call in the middle of the night, you've probably got a much more urgent condition than if you wait until the morning to call in. These call centers are open 24 hours a day, so this is an important restriction. The dependent variable in these analyses are going to be emergency department visits, primary care visits, specialty care visits, and hospitalizations. We looked over 30 days, but realized that all the action was in the first 7 days. So we're just going to present the results over 7 days. We'll estimate the association between healthcare use and nurse practitioner versus registered nurse managed calls. After adjusting for patient characteristics, so demographics and prior healthcare use and comorbidity, characteristics of the symptom from the TDP software, especially the chief complaint, duration, period, score, urgency, etc., the characteristics of the call time of day, and then we'll estimate logistic regressions and Poisson regressions to incorporate all of these factors. And then we'll also do some propensity score matching because, as you'll see, the calls that went to the nurse practitioner were pretty significantly different than calls that went to the registered nurse. So we'll just do them 2-to-1 matching within chief complaint categories. So this is what the study sample looks like. There were about 1,500 calls that went to nurse practitioners and 48,000 calls that went through the routine route. And the study sample differs on pretty much all of these variables. So more nurse practitioner calls were for females, and the chief complaint of the call was very different. And this is appropriate. Again, you only want to send calls to the nurse practitioner for things that the nurse practitioner can do something about. So as you can see, 33% of the calls that nurse practitioners got were for respiratory conditions compared to only 15% for RN calls. And NP calls, or nurse practitioners, were also more likely to get urinary calls for urinary conditions than were registered nurses. The symptoms were also less acute for calls coming to nurse practitioners. And again, this is a good thing. So interestingly, this is the ED visits in the prior 12 months. For calls that went into a nurse practitioner, on average, these callers had a half a visit compared to 3/4 of a visit for callers that were routed to the RN. So appropriately, people who are less frail are being routed to RNs. And then here's the urgency of the call. This is a variable that I constructed, and doesn't work very well. The idea behind the call was that if the software was telling you to do something today, that sounds like it's urgent. Or if it said, go to the emergency department, that sounds like it's urgent. But that's not actually, a terrific categorization. For example, if you're going to get a call from a nurse, well, that happens today. That doesn't necessarily mean that it's urgent. It just means that you're getting a call today. And then if it sends you to the emergency department, it could just be that the clinic is closing and you don't have an opportunity to go to the clinic. So this is not a terrific measure. So we're going to do the analyses with and without this urgency measure, and luckily it doesn't make any difference. So here are the unadjusted results. On the x-axis are the days since the call, so 0 is the day of the call. On the y-axis is the probability that a veteran has an event on that day. The blue line is for calls routed to the RN. The red line is for calls routed to the nurse practitioner. Here are emergency departments. So you can see a pretty big gap on the first, on the day of the call and the second day for emergency department visits. Not much for primary care visits. A little bit for specialty care visits over the week. And then the hospitalization sort of mimic the emergency department visits. So over the first 2 days, there's a pretty big gap, and then not much after that. Although you should see that this y-axis here, these are pretty low probabilities, especially for the nurse practitioners. Here are the adjusted results on a daily basis. Adjustment narrows all of these gaps, including the hospitalization. So on a daily basis, there wasn't much going on, but as you can see, over the first couple of days, calls were still a little bit elevated to nurse practitioner. I'm sorry, to the registered nurse. And so for that reason, we also estimated these Poisson models. So this was healthcare use over the 7 days. And it was a little bit lower for calls going into routed to the nurse practitioner. So let me just focus on these adjusted results over here. Here are the rate ratios for these Poisson regressions. And they're all generally less than 1, suggesting that there are fewer visits to primary care, specialty care, ED, or hospitalization if the call was routed to a nurse practitioner. And they're generally statistically significant or nearly so. And these are the number of visits avoided per 100 calls to a nurse practitioner. So about 3/4 of a visit for primary cares, and then 2.6, 5.9, 1.4 for specialty ED and hospitalization. So a little bit of a positive value for calls that were routed to a nurse practitioner. Now, because the data was so discrepant at the beginning, we also did some propensity score matched analyses, and luckily the results are pretty much the same. So again, after propensity score matching, we're looking at a little bit of a benefit. These are the IARs for primary care, specialty ED, for calls routed to the nurse practitioner. Hospitalizations wouldn't, after matching, there were not enough hospitalizations to actually run that. So the effect on hospitalizations is probably not as big as we saw on the previous slide. And this last one is, this is without urgency, and this is after adjusting for urgency. So again, urgency really didn't make that much difference, even though it was sort of a pain to put in the model. Some limitations: we did not observe healthcare use that was not paid for by the VA, through, for example, Medicare and Medicaid. And RNs were appropriately routed less acute calls to the nurse practitioners, and we may not have adequately adjusted for that. So in summary, we found that incorporating nurse practitioners into a call center was associated with lower in-person healthcare use in the subsequent 7 days compared to calls that were handled routinely by a registered nurse. And I'd like to really thank my collaborators on this: Eric Gunnick, Jorge Rojas, Ryan Laundrie, Chris Wilson, Emily Ashmore, and Peter Capaldi. Thanks.
Dr. Haun has just made you the presenter, so you should be able to share your slides.
Can you see them?
Not yet. you go to share across the bottom.
Yep.
There you go, it's starting.
There we go.
Right, all set.
Hello, I'm Dr. Haun, and I will be presenting findings from an ongoing implementation study that is using a community-based participatory approach and concurrent mixed methods to, 1, identify characteristics that impact virtual resources use by PACT team members, 2, develop implementation strategies to promote their adoption of virtual resources, and 3, evaluate a local implementation of PACT-focused implementation strategies to promote proactive integrated virtual resource use. The purpose of the study was designed to inform the VHA's system-wide implementation efforts to increase proactive integrated use of virtual resources among primary care team members. Before I present the project finding, let's define the concept of proactive integrated virtual resource use. We define this concept as the self-initiated, coordinated use of applicable virtual systems as a team for the purposes of coordinating timely delivery of high-quality care across the care continuum. Proactive integrated resource use is important because it improves workflow and workload, supports provider uptake and promotion, and can increase patient adoption and sustained use to improve care outcomes. Research strongly suggests provider use and promotion drives patient use of virtual resources. Though proactive integrated use of virtual resources is not currently a widespread practice, the long-term goal is to create a cultural norm for integrating virtual resources seamlessly into the workflow of care delivery to optimize veterans' VA healthcare experience. Here's a visual to illustrate proactive integrated virtual resource use. Prior to her retirement from the VA, Kim Nazi, a senior member of My HealtheVet and one of our co-investigators, created this model to represent the different phases of the healthcare continuum, with the vision of integrating virtual resource use across the continuum to support team member use, veteran use, and shared activities by veterans and their healthcare team members. To the right of this visual, there is more than 20 virtual resource tools available within the VA healthcare to integrate self-care and healthcare management. Now that I've briefly reviewed the fundamental concept and overarching aims of this project, I'll present the general findings of Aim 1 and Aim 2 of this project, in which we explored current virtual resource use among PACT team members and their experiences, including facilitators and barriers, their preferred implementation strategies, and the development and formative evaluation of patient-aligned care team virtual resource implementation toolkit. From the focus groups and interviews, what is most notable from this project is that we gleaned little evidence of proactive integrated virtual resource use, except in the case of secure messaging and a few identified super users. We identified facilitators and barriers which were consistent with the literature. Ease of use and useful functionality were facilitators, whereas lack of awareness of tools, suboptimal functionality, workflow disruptions, and increased workload were identified barriers. Lack of knowledge of resources prevented use as well as prevented promotion of veteran use. Though we recruited PACT teams with highest and lowest virtual resource utilization, we found minimal differences between these groups. But those differences identified included that high user groups tended to focus more on concepts such as functioning equipment, familiarity, and accessibility of virtual resources, while those low user groups recommended system changes such as workload credit and infrastructural support. Though both groups identified education and training as necessary implementation strategies, low user groups identified significantly more strategies to support their use. What was clear from the data was team members need best practices of proactive integrated use that are specific to care tasks and performance measures. Following data collection with PACT teams, We worked with expert informants to identify 23 virtual resources that could be proactively integrated across the care continuum and started a process of connecting those resources to tasks and performance measures. I'll present more about this, but let's first look more closely at the PACT team's recommended implementation strategies. As a part of data collection, we presented PAL's published implementation strategies. This table illustrates those strategies selected by the two groups. Though low utilizers selected more strategies, which is somewhat intuitive, suggesting that they expect more strategies to motivate their use, both groups predominantly selected education and training related strategies, technical and infrastructural support, and system-based enhancements, which were also clearly warranted based on their responses. Beyond those strategies, mandates, workload credit, and credit for training were specifically discussed. This is promising, as we've seen within the VA system. These strategies were very effective in the adoption and sustained proactive integrated use of secure messaging within the VA. It should be noted, as a researcher who started my research career studying the implementation of secure messaging nearly 10 years ago, it took nearly a decade for secure messaging to go from the flavor of the day to a virtual resource that is now proactively integrated into the daily workflow of care delivery as a cultural norm. Let's take a quick look at secure messaging as a virtual resource that is proactively integrated into PACT team workflow. As seen here, we have developed a visual representation of how different PACT team members integrate secure messaging into their workflow for different tasks. Though this is an ideal example of proactive use, there are more than 20 virtual resources that could be effectively integrated into workflow by several team members across the healthcare continuum. As a result of these project findings, with the intention of identifying educational content that presents opportunities to proactively integrate multiple virtual resources to complete tasks throughout the healthcare continuum, here I've illustrated examples of tools that can be used by PACT team members. We have also created this inventory for veteran tasks and shared tasks, but this is just a preliminary product that can grow over time to include more tasks of these three groups. So each of these numbers represents a tool from that previous list of more than 23 tools. This could be expanded to include those tasks that can include informal caregivers, delegate activities within different systems of care that are specific to complex coordinated care tasks and performance measures across more discrete phases of the continuum of care. Based on the AIM-1 focus group and interview data, it was clear educational content and preferred implementation strategies were warranted. In AIM-2, we conducted an environmental scan and reached out to subject matter experts to collect virtual resource materials across the VA system. We collected 144 resources that were reviewed and ranked on 5 measures as seen on the slide. Though 141 measures and resources were included, none were PACT specific, and most resources only promote awareness building and address only one resource. As the toolkit continues to develop over time, there is a clear need for more content that focus on access and skill building for use across multiple resources that can be tailored for specific services such as primary care. As such, we created a tailored patient-aligned care team virtual resource implementation toolkit, which includes implementation and dissemination plans, training, fact sheets, linked resources, and the previously presented healthcare continuum with options for integrated use. Resources include videos and presentations and other materials. Notably, we produced videos that contextualize the toolkit training to be delivered within the context of primary care with examples of proactive integrated use with exemplar patients. It should also be noted materials were most commonly available for only about half of the virtual resources currently available within the VA. But we attempted to organize those resources by care task to make the content most useful to users. So we conducted a formative evaluation of the toolkit. Beyond the internal subject matter expert review, we conducted a dynamic training in which we presented an overview of the collected resources. Overall, respondents found the toolkit training useful, preferred the dynamic context-specific videos, and especially valued information of emerging VA virtual resources such as anti-texting. Notably, during the training, group discussion facilitated learning effects and presented an opportunity to introduce champions who offered support to their peers. Some challenges that should be addressed as we consider large-scale dissemination include: 1, dedicated time, space, and credit for training, as well as issues with technical challenges when delivering training, especially when delivered remotely. Unfortunately, our system has virtual connectivity issues that can deter virtual resource use. It is prohibitive to have those issues when delivering training about the use of these resources. And finally, what was most concerning to our team was that some training attendees didn't see the connection between their use of virtual resources and patients' use, and felt that training should fall on the patients. Whereas we know, based on the body of research that is available, provider use and promotion drives patient virtual resource use. Here are some images that give a general idea of the virtual resource content that is included in the toolkit, but there is a clear need for development of resources and content that address additional available virtual resources, examples of proactive integrated use that address complex coordinated tasks and performance measures, individual, team, and patient-based examples, content to motivate team member promotion to patients, and materials to provide to veterans, as well as their informal caregivers and delegates. In conclusion, though this study is ongoing through spring of 2021, we know the project gleaned little evidence of proactive integrated virtual resource use. As such, awareness, knowledge, skills, and infrastructural support and enhancements are warranted. Best practices to achieve performance measures and complex coordinated tasks across the care continuum are needed. Strategies including mandates, workload credit, accessible dynamic training, and credit for training are critical. And the toolkit requires ongoing development and dissemination with operational partners. To maximize spread and impact, we are partnering with the Office of Connected Care and their Academy representatives to support dissemination. Finally, attendees may be wondering if this project is now outdated due to the COVID pandemic related mandates to deliver care virtually to reduce contact. Because our project is ongoing, and our third aim is collecting primary survey data and secondary virtual use data, we have learned that though there has been an increase in use of virtual resources such as telehealth, the increase is still reactive in nature. Due to abrupt transition during the pandemic, not all virtual resources have been fully integrated or realized for their usefulness. There is still a need to motivate best practices of proactive integrated use into workflow as a cultural norm. Instead of a few select super users, we can create a culture of virtual resource super users. Thank you for your time and allowing me and my research partners, Bridget Kottner and Christy Malelo, to share our work with you.
Dr. Wray, I've made you the presenter. You're going to need to forward the slides to your section.
Okay.
Thank you.
Thank you. Wonderful. It's a pleasure to be here. Again, my name is Charlie Wray. I am a clinician and health services researcher at the San Francisco VA. I'm going to take the next 10 minutes or so to discuss my recently funded VA HSR&D Career Development Award that's titled Improving Access to Care for Socially Vulnerable Veterans Through the Focused Delivery of Telemedicine. I think we have a crowd here that understands the importance of access and access failures and how these can actually impact care. So access to care is actually a very high priority within the VA. The two types of, or rather the access failure that I'm going to be discussing today, of course, are called missed clinic visits, or more colloquially known as no-shows. If you look at the literature writ large, primary care no-show rates have ranged between 15 to 30%, but the VA has done a little bit better at this with no-show rates usually being around 15 to 20%. But as clinicians and researchers here probably know and understand, no showing or missing clinic visits can have a profound impact both at the individual and systems level. No-shows can lead to interruptions or discontinuity of care. Research has shown that it's increased rates of hospitalizations and greater resource utilization across the board. At a systems level, no-shows lead to scheduling and operational inefficiencies. It can reduce clinic productivity. And not only does it reduce access for the veterans who miss their clinic appointments, but it actually has been shown to reduce access for all veterans as well. In 2017, the VA found that there were approximately 9.2 million missed clinic visits that ended up costing around $500 million annually. So you can see that there's a substantial impact on care and financial issues when veterans essentially miss clinic visits. So I'm going to talk a little bit about some of the research that drove and was the impetus for my Career Development Award. And one of the first questions that we asked was, okay, if we have this issue with access failure, who's actually at risk for these failures? And there's good research outside of the VA setting that has shown that people who have social vulnerabilities, and when I use that term, I'm referring to individuals who suffer from homelessness, poor mental health, or substance use disorders as examples, that such individuals have had poor access to care. Now, the question that we had was, if we're going to explore this, we first actually need to understand and have the ability to extract social risk factors from VA data. So myself and colleagues did a study a couple of years ago looking at our abilities to extract social risk factors using national VA data. We created 6 measures of social risk using ICD-9 stop codes, ICD-9 codes, clinic stop codes, and laboratory data. And what we did was a chart validation assessment, essentially asking the question was, if there's any indication that these risk factors exist through ICD-9 stop codes or lab data, is it truly being manifested in the chart as well? And we looked through these 6 social risk factors that you can see here on the left. And as you can see here, the prevalence, while not terribly high, and I think most of us probably walk away saying that this is probably an underestimate, but the thing that actually gave us some confidence was that our positive predictive values for most of these risk factors was actually fairly decent. And what this meant to us, or signaled to us, was that if there was some sort of clinical indicator, at least in the administrative data of social risk, that we were fairly positive that that social risk actually existed for that individual. The next question we asked ourselves was, well, is social risk actually associated with missed clinic visits? So we took a convenient sample of a cohort that we had available to us that consisted of 1,500 elderly veterans who had been hospitalized for heart failure. And we looked at the overall prevalence of missed clinic visits and tested the association of social risk factors with having a high missed clinic visit rate. And as you can see here, the vast majority of the patients actually had 1 or fewer missed clinic visits in the prior year, but about 1 in 7 individuals actually had 2 or more missed clinic visits. And those who actually had 2 or more missed clinic visits had higher prevalence of all analyzed social risk factors compared to those who had 1 or fewer. When we modeled this out, you can see here that the adjusted odds for having 2 or more missed clinic visits was actually significant for individuals who had factors of living alone, those who were marginally housed, and those who suffered from substance use disorder. So again, this sort of buttressed our idea that, again, individuals who are at highest social risk are individuals who are potentially not showing up for their clinic appointments. The next question we asked ourselves was, is if these individuals aren't actually coming to the VA, if they're not showing up for their appointments, how do we bring the VA to them? And I think this was the answer that we had in our mind was, of course, telemedicine. And in 2019, of course, prior to the pandemic, the VA, I would easily argue, was a leader in telemedicine across the board. And I think we've sustained that leadership even through the pandemic. But at that point in time, we said, well, look, we have telemedicine, which is meant to improve access to care. Why don't we think about using this to engage individuals who are socially at risk? Most individuals here are familiar with VA Video Connect, otherwise known as VVC, which is a mobile application that was designed in 2017 to connect providers and veterans together. The VA stood behind this so much so that in the Mission Act of 2018, it was a top priority in increasing the VA's telemedicine outreach as a means to improve access to care. The VA actually felt so strongly about this that it had mandated that 100% of all providers be VVC capable by the end of fiscal year 2021. Now, again, this was prior to the pandemic, and the pandemic, I think, of course, shifted us in this direction much more so than what was probably imagined when this was initially written. But one of the questions that we asked was, while we mandate that telemedicine be used broadly, are there other subpopulations who could potentially benefit from the use of telemedicine outreach? And while telemedicine is often focused on veterans who live in rural or remote locations, again, we postulate that other populations may also benefit from the use of such services. The eHealth query, which I believe Tim Hogan ran, or is still running, found that among a cohort of surveyed veterans, most actually had access to a smartphone, tablet, and or a laptop computer. So the idea that many of our veterans lack the ability to connect or lack some of the resources may not hold true writ large. There's also research that's demonstrated that vulnerable veterans, homeless in particular, are technologically capable. So they have these skill sets and they have the desire for video-based care as well. So while there indeed is a digital divide that exists in the world, it may not be as profound as we may believe. So we thought that evidence does support the idea that VVC may be a useful tool to connect socially vulnerable populations and to be targeted at those who are at elevated risk of no showing a clinic appointment. On the other end of the spectrum, we asked the question of whether or not providers believed that socially vulnerable individuals, or rather, did providers have the capacity to know which individuals would be successful or could actually use telemedicine per se. So we ended up doing a survey at the San Francisco VA, and we asked 33 physicians after their initial use of VVC through a certification course. And we asked them multiple questions, but the one that really stood out to me was this top question here that said, my comfort level with selections of appropriate patients for video visit is around 50%. So only about half of our respondents actually felt that they knew whom they should be referring for telemedicine. And so again, we saw a gap here that we may be able to potentially fill. So this drove, I think, the larger question for my grant, which was identifying veterans who are at high risk of missing primary care clinic appointments and understanding which subpopulations may potentially benefit most from VA Video Connect. Now, this diagram here largely outlines the grant I submitted here, and I'm going to go through these very quickly over the next couple of slides. The first aim, the goal is using regression trees, which is a machine learning technique to phenotype veterans based on their estimated risk of no showing clinic appointments. Now, what regression trees are is they derive a prediction model that actually gives you two outcomes. It estimates the probability of having a high no-show rate, but it also can phenotypically describe the veterans who are at high risk of access failure. So if you look at this hypothetical output here, you can see that we've taken a general VA population. We've run the model, and the output looks like a tree, hence a regression tree. And if you look at the bottom nodes here, you can see that there are two outcomes. Again, the probability, which is represented as that percentage within the node, that an individual would potentially miss a clinic visit in some period of time. But it also phenotypically describes the patient to us so that we can actually understand, from a clinical standpoint, what do these patients look like and what are they suffering from? Aim 2 is looking to use mixed methods to engage the phenotype individuals from the first aim who are at high risk of no-showing and assess their suitability, desire, and capabilities of using VVC as a means of obtaining access to care. Again, if you look at the figure here, we take the highest risk individuals from aim 1, and we're going to qualitatively assess the facilitators and barriers to engaging through digital care, and also potentially why they're actually missing clinic visits as well. The hope is then to develop a survey instrument that we can then apply to a more generalized population to see if we can actually generalize the findings to other individuals who are also missing clinic visits. The final aim is actually piloting the targeted use of VVC among veterans who are at risk of no-showing primary clinic appointments at the San Francisco VA. We're going to use implementation strategies around using formative and process evaluations to assess environmental, systems, and individual characteristics that could potentially help us inform a focused utilization of VVC amongst high-risk individuals. And the goal of this is actually to provide us some preliminary effectiveness data to help guide in the future design of a larger study to test whether or not we can focus the use of VVC on high-risk populations. With that, I'm actually going to hand the microphone back over to Dr. Shimada and Dr. Hogan.
All right, great. Thank you for these wonderful presentations. I noticed that there's some questions in the Q&A that we've been answering, and I believe Rob will read off any questions that have been asked.
Thank you. The first one up is, this person writes, I am wondering if the VA has any efforts to examine these measures, and in parentheses, research around access and proactive use of integrated virtual care, close parens, among community care providers, since community care may become more prevalent for veterans since the Mission Act.
Can you repeat the first part of that question, Rob?
Sure thing. I'm wondering if the VA has any efforts to examine these measures, meaning research around access and proactive use of integrated virtual care among community care providers.
Community care meaning non-VA, or community care meaning the PACT teams?
I'm sorry, I don't have that information.
Okay, so the VA is looking at utilization among diverse user groups. Of course, it is predominantly within the VA system. One of our projects specifically, I did not present it today because it wasn't the focus of today's presentation, but we are actually collecting secondary data across all of the virtual resources that provide available data. And we are looking at utilization pre and post our implementation project, which coincidentally is pre and post the COVID pandemic. Well, not post-COVID, but the onset of the COVID pandemic. So we are looking at this work, and we have a lot of collaboration efforts with the Office of Connected Care. So this work is ongoing. They also have internal efforts that they are conducting to support this work, not only among primary care, but the general system.
I also wanted to add in and draw people's attention to the slide on the screen. Right at the center is the VARC intranet site. If you go through that site, it will take you to the access measure compendium that Dr. Kaboli and his team have been pulling together. We're hoping that anyone on this call or your colleagues, we encourage anyone to add metrics to this compendium. We're also, as we mentioned earlier in the presentation, hoping to stand up a cross-core work group that will work on measures that are specific to virtual care access.
At this time, the only two remaining questions that we have, Stephanie, you've answered, and Jolie, you answered, but if you'd like me to read either one and you can answer verbally, we could do that now.
Sure.
So that was for Dr. Shimada. The question was, Is the VARC Network Access Research Evaluation mentioned at the beginning available to researchers outside of the VA?
So currently our resources are primarily on the intranet site. The Access Measures Compendium that I just mentioned is hosted on a site that is currently trying to evolve into an externally available site. And so we're hoping that along with that, we will become more readily accessible outside the VA firewall as well. There's limits to what we can post outside. However, like we do try when we can to share things through our mailing list. We send out periodic emails. I know VARC does, and Virtual Care Corps is starting to do this as well to the community to keep everyone informed about resources or new research. We invite people to share their work with us so that we can share it with the whole network. So if people outside the VA sign up, or people within the VA sign up with their non-VA emails, we are able to send that information out to that location as well.
Thank you. And then the other question was one for Dr. Haun regarding a citation. Let me see if I can cue it up.
Yep, you've got it right there.
And it's on this slide? The answer is?
Yes, sir. And as well, as I mentioned previously, this was a large IIR with multiple aims, some of which were not addressed in today's presentation. And so you can learn more about available secondary data resources for accessing and analyzing system use with secondary data. And that's also in the protocol, as well as the literature that was requested in the chat.
Great. Well, that was the last question that we have queued up, and it's actually a little bit past the hour. So if anybody would like to make closing comments, I'm not sure, maybe just you, Dr. Shimada, or you can decide, I guess.
All right. Well, thank you. If we could go back to the very last slide.
Absolutely.
I just wanted to highlight to people that since I was just trying to answer a question in the chat about how to get engaged in the course, we really want to encourage anybody, especially at junior career stages, to get engaged in one or both of these cores. It's really easy to send us an email. Each core has sort of a core Outlook inbox that you can send a message to sign up to get on our mailing list and get engaged with activities. If there's something specific you want to get engaged in, please say that in your message. There will be opportunities to participate in various work groups and also hopefully some cross-core projects as well. Thank you so much, everyone, for attending today. I know your time is precious, and we appreciate everyone joining.